Welcome to our first HealthStack Summit. I'm Morgan Devon, CEO and founder of Blavity. Type into the chat where you're tuning in from. I'm so excited to be here with you all today. Charlotte in the building, Nashville in the building. You all know I live in Nashville, Tennessee, although I'm from St. Louis. We've got a lot of Nashville. I love to see it. DMV, Miami, Philly, Houston, Dallas, Cancun. Okay, you're on vacation, Glenn. What's going on over there? Raleigh, Maryland, Bermuda. Nice. LA, Roswell, Houston, Seattle. It's so good to see you all. I'm absolutely thrilled that we are starting the day together here at HealthStack. This is going to be such an amazing conversation, and I cannot wait for us to get started. We're going to let everybody tune in. Oh, we've got almost 176 people, so actually we're going to get started in just a few minutes here. Kate, I can weirdly see your name. You might have to pin me. There you go. Thank you. This is so exciting. Welcome, welcome to everybody. Thank you on the congrats on the baby. Yes, baby girl is only 3 months old. She's living her best baby life. I'm happy to be back to work with you all and with the team. All right, so I'm gonna just talk a little bit about why we started HealthStack, and then I'll pass it off to my amazing team and colleagues to get started on today's summit. So if you're new to Blavity and Afrotech, I'm the CEO of Blavity, and Blavity owns Afrotech. We've been around for over 13 years. I started my career in St. Louis, where I was born and raised, and I went to WashU for undergrad. And my father is a doctor. So I grew up listening to research calls. He was a doctor at WashU, as you all know, is a fantastic research institution. He's a pediatric hematologist oncologist and primarily focuses on kids with sickle cell disease. So I literally, he would drive me to school every day and I would hear all the clinical trial back and forth. I would hear all the secondhand information, not really knowing what I was hearing, but really understanding that he was advocating for people and children who were being underserved by our practitioners, and that the research was not there, that the standard of care was not there, and there needed to be more advocates who were fighting every single day to ensure that we got our fair share of NIH funding to do research trials to improve the outcomes, that we were training clinicians, nurse practitioners, um, ER doctors, people who are at the front lines for many of these patient populations. And then eventually he moved overseas to Nigeria and Ghana to work with different countries on their standard of care and making sure that they had the right technology to do things like blood transfusions at a young age for these babies and run blood drives to make sure that there was enough blood for these children. And it's very, very important to me growing up. That was what instilled the sense of equity for me. It was this thing that I was like, okay, I don't know if I want to be a doctor. Like, shout out to all of you all who went to school for many, many years. But the idea of making sure that my career was aligned not just with something I'm passionate about, but something that actually is making an impact and a long-lasting impact to provide change. And Afrotech at its core was about shifting industries and creating information, gathering community, and really also reducing information asymmetry so that our communities and communities of color could have equal access and equity to the tech industry. And now that Afrotech has been established, we'll be celebrating our 10-year celebration this year in Houston, Texas in the fall. We've decided to continue that legacy and expand and build out a new mission, which is HealthStack, because we have the know-how, the network, the trust from our communities with all of our media brands. HealthStack is designed to help make sure that you all as providers, the ecosystem of people who care about our people, have the resources, the information, the community that you need to leverage things like technology, AI, to be use things responsively, the data sets that are required, thinking about clinical trial diversity and ensuring that our community knows how important it is to participate in these clinical trials and why we should be doing this. Type one into the comments if you are with me. This is why we started HealthStack, okay? This is why we decided to build out this community. And I'm so excited that you're here with us today for the first ever HealthStack Summit, which is virtual so that we can be accessible to every single person in our community who's curious, who wants to do the right thing, who wants to learn, who wants to advance, and wants to connect with each other. So, things you can look forward for the rest of the year. We'll be exploring doing more of these virtual summits and making them topical based. Two, we'll be in Martha's Vineyard in August. If you're interested in partnering with us, if this speaks to you and your work, if you work for a big company who's curious or interested in reaching this patient population or reaching providers, please connect with us. We'll most likely be in Puerto Rico for NMA. So, working through that. So, if you're going to be an NMA, type two into the chat. So we're also looking forward to partnering with all the legacy organizations that have done so much, the shoulders that we stand on. And of course, we'll be back in Houston for an expanded health stack experience in person. And I'm so excited. Make sure you stay to the end of today's session because, of course, we're going to give you a little something special to make it easier for you to join us in the fall. And with that, I pass it over to my amazing colleague, Simone Tyler. Bye, everybody. They might have some things going on backstage. For those who are just tuning in, make sure you type into the chat where you're tuning in from and the companies that you're working with. Okay, amazing. LA in the building, Phoenix in the building. Vel and team, you guys are gonna make the transfer? How are we doing?
All right. Hello, everyone. My name is Simone Ashley Tyler. I am excited to be joining you. I am the Senior Vice President at Blavity Inc. It looks like we've got a lot of amazing people here in the house. Thank you for joining us. Continue to drop what city you are joining us from. We are going to get today's conversation started. First off, I am going to introduce our first speaker. She is someone who's been at the forefront of digital transformation in healthcare. Anika Gardenhire, RN Chico, is the Chief Digital and Transformation Officer at Ardent Health, where she led technical teams through an IPO and ensures technologically supporting consumer focused strategies. She's a former bedside caregiver, turned Fortune 25 executive with board level expertise in cybersecurity, digital health, and clinical informatics. She holds degrees from the University of South Carolina, a dual master's from Duke, and today she is going to walk us through how ambient AI is changing documentation in the examination room and the real considerations around bias, which I know we all care about, privacy, which we all care about, and patient trust. Please join me in welcoming Anika.
Thank you so much for having me. And thank you so much to everyone for joining on a Friday, just afternoon, at least if you're in Central Time. Um, so I'm going to share a couple of slides, but really want this to be as interactive as possible. I'm trying to watch the chat and I'll maybe ask for some help from Simone and or Morgan to call out things if there are places where we want to pivot. But here, let me share. Awesome. I'll just go. So we're going to talk a little bit about enhancing care at the bedside, specifically using ambient solutions, but we're going to talk more broadly about artificial intelligence at the bedside as well, and where there are several different applications that are being looked at. And I will also share with you all, AI helped me create this deck, and I left some of the nuggets and mistakes that it usually makes in here on purpose. Several of them I pick out and then I create my slides on top. but really want to help people start to get a feel for, I think, the usefulness of these tools across many different applications. And we'll also just talk about a basic understanding of sort of how the models are being developed and the tools that are being developed on top of the models. But actually, just yesterday, I had the opportunity to talk a little bit about some of our ambient solutions, and so I'll share an article with you that just came out in U.S. News and World. But there are multiple applications, and so I wanted to talk about that as well. So real-time clinical decision support, right? So when you think about the monumental amount of data that comes out of the tools that we use at the bedside, as well as, quite frankly, the monumental amount of data that a clinician who's standing at the bedside with a patient can get from their five senses. Trying to aggregate that to come to conclusions and decisions and have that happen in a very rapid fashion is one of, I think, the best applications that we're going to get from a lot of the augmented intelligence, artificial intelligence, however you want to state it, tooling. Having monitoring and prediction, that's everything from monitoring of equipment and vital signs to computer vision to understand whether or not people might fall. Efficiency in the documentation, and that's what we're going to spend a good bit of our time talking about. But if you think about the amount of work that goes into documentation, and the reality is a lot of the historical sort of development of clinical documentation was developed around billing processes, but they weren't necessarily developed around the process of telling a patient story or communicating from one clinician or to another, or creating a good longevity record around a patient's lifespan. And so being able to do all of those things with one set of documentation, I think is one of the ways that these tools are going to be helpful at the bedside. And then ethics and patient trust. And so making sure that you have very, very strong digital ethics becomes an incredibly important part of the infrastructure for being ready to utilize, I think, any of these tools at the bedside. Making sure that you are able to do things like understand digital literacy or train people to consent. And we'll talk a little bit about that as well. But wanted to start with just understanding how ambient solutions are helping at the bedside. So I thought I would just share, we have talked about this from an Ardent lens a good bit, but when we rolled out our ambient solution here, we started with pilots. We piloted multiple solutions and ultimately landed on a solution called Ambient. But I think the most important things to understand around this are this does not just go viral. And so the things that we understand about rolling out new technology, especially to clinicians, but also to patients, is really important. So the change management required, the adoption work, the education and training, all of the work to allow people to become accustomed to the tooling, but also questioning the tooling itself, making sure people understand where they should trust it, where the tooling is meant to check the human versus where the human is meant to check the tooling, understanding the edit responsibilities for the clinician for the note that's being created. But when we started to roll this out, our goals were very clear, right? We have a significant problem in this nation where we are losing clinicians at the bedside faster than we can replace them. And we have a population that is aging into needing care at a rate that's really untenable for the number of caregivers. And I mean caregivers holistically. That includes those in your sort of personal life, right? Mothers and fathers and sisters and brothers, as well as those that might have a professional, right, relationship with you. And that's everything from home care to providers to nurses to PT to OT to speech to everyone. And so how we keep people in the professions, as well as equip those people who might be surrounding someone as that personal caregiver team becomes really important. And when you think about ambient solutions, one of the things that is very, very critical to center around any patient or consumer in the healthcare journey is how we communicate, how we capture the things that happen, whether that be episodic or whether that be across the lifespan, and then how we take that information and communicate it to the other members of your overall caregiving team. And so we were focused on making sure that we could recruit and retain providers as a part of this work, because one of the things that we definitely hear from providers is the tax that documentation places on them, and the fact that, quite frankly, many clinicians just simply did not go into the work to do things other than direct patient care. And so the point of this is to give people back time at the bedside and to make sure that we are doing that in a way that is safe and effective and ultimately still meets the goals of clinical documentation, which is a good capture of the episode that happened with that clinician, a good understanding of that overall patient story, and the ability to communicate that to the rest of the care team. And since deploying our solution, we have seen a significant adoption rate. And that means we're seeing over 90% of providers using this at the bedside and having a significant number of the encounters being closed at the end of the visit. And so you might have heard this conversation around pajama time that's happening. But the goal is to end that pajama time. It's to be able to give clinicians back quality of life, but also to open up access to patients. And so when you're more effective from a documentation perspective, you can add that add-on case that you needed to add for that long-time patient who needed to see you in the clinic. You can go by and do that hospital visit for a patient that may have been admitted that was unexpected without fully disrupting your patient day in clinic or maybe your surgical day. And so at the end of the day, our goal is to make sure that we are providing the tool set that gives clinicians quality of life and does so in a way that is highly effective for patients and has high integrity for making sure that we are telling that story. Before we started, we did some surveying, and what we were seeing was that clinicians, particularly providers, were spending about 200 minutes of documentation per 8 hours of visits in their clinic. And that is an incredible amount of time. And as you can imagine, a lot of that time was happening outside of the patient care hours. So either pre-clinic or post-clinic, or in between and on the fly, which often meant that that was taking away time from family. And after we implemented these tools, we definitely saw a significant satisfaction from a patient perspective, just even in how you think about positioning yourself in a room when you have a patient come in, and turning your body toward the patient instead of toward the laptop. Having more time to be able to explain things, having more time for the patient to ask questions. And so a lot of satisfaction, both from a patient perspective as well as from a clinician perspective. But I do think it's really important to understand sort of the opportunities and benefits, but what do you need to do in order to be ready to implement these types of tools at the bedside? And so I think there are a couple of things, making sure that you understand what it is you're focused on. Are you thinking about decision support? Are you thinking about documentation? Are you thinking about monitoring, predictive analytics? Because there are different types of tools depending on the application that you are working to provide. And so we holistically at Ardent think about these different areas and, quite frankly, other applications, front office and back office applications as well, that we are focused on making sure that we're thinking about how we place these tools appropriately and how we assess them. There are no shortage of providers of these tools in the marketplace for sure. And so you do need to have a way to evaluate as well. But then really, really importantly, do you possess the basic capability inside of your organization that will help you do things like evaluate equity and mitigate bias in any of the tools that you might be purchasing? And so being able to do your own A/B testing, understanding your own, for example, consenting processes, being able to train everyone in order to consent the patient so that patients understand the use of these tools inside of their clinical care, and can make determinations about whether or not they want to have these tools be utilized. And then the biggest thing I think is making sure that there is understanding that there is going to be a human in a loop. And if that's true in your organization, that these tools are not autonomous and that providers ultimately and clinicians ultimately have responsibility for the clinical care that's being provided. I think the other piece is making sure you have very clear safety protocols and governance frameworks in place for how you make determinations around things like data use, and what can be utilized on which type of patient. Are there minimum requirements? Those types of things. And then I wanted to talk a little bit about a few key definitions that I think are really important, because I think we've gotten to a place where we're sort of calling everything AI. And there are a lot of different tools out there that can be used for different things. And so robotic process automation, I think, has become somewhat of an oldie but a goodie, right? So when you have those types of repeatable tasks that you want to automate, you don't always need something agentic or a large language model in order to do that. Agentic AI systems are also really important, but I think understanding why you're using those tools becomes really important. You have large language models. And then I think model performance, being able to understand how a model that you're using is performing becomes really important. And so what is the propensity? What are the sensitivity levels? And making sure that you have some understanding of those. And I apologize because this is the part where I get like super nerdy. But I do think that it is really important that there's sort of a basic understanding of the tools that we're using. I've always been really curious about anything, I think, at the bedside. And I think from a clinician perspective, especially as we think about the fact that some of these tools, quite frankly, are going to be less regulated or less researched than other interventions that you might bring to bear. So for example, do you have the same sort of propensity and sensitivity levels for some of these tools that you have in sort of drug development? Was the same type of research done? And for as long as there, I think, are differences in those things, I think there's more responsibility on the clinician or the person using the tool or the organization bringing that tool to bear. So I do want to help people, I think, also understand just sort of, and I will continue to reinforce, right, the organizations that are developing these, the importance of ethical AI and safety, in making sure that you understand sort of what's happening with these models. So most of the things that you're going to see in the marketplace are developed from, built upon, utilizing as a backend a few basic models that were developed by people who had lots of dollars, right? What it actually takes to create large language models is incredibly intensive. Just building out the data centers and the infrastructure from a capital perspective, it is not for the faint of heart. But for most of what you will see in the marketplace, they were developed on the back end of some of these models, but they each actually have their own sort of propensities, right, that they are best used for. And so I put a little table together so that I think people can sort of just get a high level understanding of the tools that are out there and what might be used. So at a minimum, questions that you might ask, right, maybe a digital provider who's bringing something to your organization. What was your backend? How did you train the model to be more specific to the problem that you are trying to solve? What is the data source that you've utilized to train the model? Will you be using my data to further train your model and make it better? And if so, what do my patients or my organization, quite frankly, get for that? And I think it's really important to have an understanding as well, even in your personal use. Lots of folks are using some form of Gemini or ChatGPT, or you might be using Claude. I'm a huge fan myself of several of these tools. I was a huge fan of Haiku and Sonnet. I think the tools for Meta are also, and I said personal opinion wise, I think that these tools are best utilized for their natural propensity if you understand what that is. And so included just some high level information here, and happy to try and answer questions about that as we get into a little bit of Q&A. Really, really, really important. What do you need to do before introducing these tools into your organization? And I always tell people, I think the infrastructure for onboarding AI is as important as the AI itself. So have you looked at and updated your consents? Have you talked to your compliance teams? Do you understand what's happening from a regulatory perspective? And there is a huge amount happening even at the state level. So if you are a multi-state organization, understanding what's happening at the state level is really important. Have you trained your teams, the people who are going to be using it, and the people that it's going to be used on, right? Do you understand the basic digital literacy levels of, for example, your patients? If you offer a virtual AI solution, does the person that you're offering it to have the basic digital literacy propensity for that to be appropriate, normal, and customary for that individual? And then are you doing work around risk ethics and how are you thinking about your risk policies? So your overall insurance policies. And then how are you monitoring the tools that you're using, right? Because these tools naturally learn over time. That means they can create drift. Do you have a governance model that says we're going to come back and test these tools, that they're not developing bias over time, right? That they're not creating drift over time or doing things that we don't expect over time. And so you need to have a basic capability inside of your organization to understand that in some way. Otherwise, you are placing a lot of trust in your vendor partners, which I wouldn't necessarily say is a bad thing to do, but then they owe you the answers to these questions just as well as anyone else. All right. Those are the slides. Happy to answer any questions. I'm going to stop sharing and then I will check the chat here.
It doesn't look like we have a whole lot of questions here,
Whole lot
but
of questions.
opinions. I'm curious what everyone would say are their favorite LLMs and tools that they're currently using. Some people are saying Doximity, which I don't think was on your list. Any other thoughts, questions before we wrap this? Favorite is Claude. I am a Claude girly as well. Fantastic. Well, first, thank you so much. We're really grateful for this conversation to kick off. We will be sharing this on the back end so you guys can take those lists of questions as you are in your day-to-day practices and make sure that we are asking the right questions as we move into this new era of healthcare. Anika, thank you so much. Much appreciate your time today.
Absolutely. So happy to be here. And thank you so much, everyone.
All right. For those of you who just joined us, please drop your city in the chat. Where are you joining us from? We're very excited and helpful to know where you all are going and where you're coming from. Also, your organization, but not just your organization. What is the work that you do? As we build out HealthStack, are incredibly interested in what you guys care about. What is the work that you're doing every single day? The areas that are most passionate to you as we kind of continue to build out this programming. We've got Austin, New York, North Carolina, Texas, an analyst from Atlanta, the DMV. All right, New Jersey. Not a lot of West Coasters in the house, not a lot of East Coast, Texas folks. All right, fantastic. Well, thank you so much for joining us. This was a great start to our conversation. We have a few more conversations left. And so I am going to go ahead and introduce our next set of speakers. So next, we're shifting into a conversation about equity. Specifically, how do we build healthcare solutions that don't just scale, but actually reach the communities that need them most? Joining us are two leaders doing exactly that. Dr. Alani Gregory is the head of health equity and belonging at Amazon One Medical, where she leads strategy to integrate health equity across care, delivery, and innovation. She was named a 40 under 40 in healthcare by Black Health Connect. She's a proud member of Alpha Kappa Alpha Sorority Incorporated and completed her medical training at Columbia and Yale. We also have joining us Dr. Ian Tong. He is the Chief Clinical Officer at Foresight Labs, where he's incubating companies at the intersection of care delivery and data science. He previously scaled Doctor on Demand from seed stage through pre-IPO. That is a very big deal, and was co-executive sponsor of the Diversity, Equity, Inclusion, and Belonging at Included Health. Please welcome me as we welcome Dr. Gregory and Dr. Tong.
Hey, Simone, thanks so much for the intro. And Dr. Gregory has allowed me to use her first name. So we're all family
We're
here.
all
So,
family.
Alani, thank you so much for joining us. And yeah, and congratulations on just, a pretty amazing career to date. I know you're younger than me, so you're in the earlier stages of it. But yeah, great run in the last 6 years here as well, 6+ years, I guess at One Medical as the head of health equity and belonging, and you're still seeing patients as well.
Yeah, I see patients about 2 days out of the week, and I love it because it helps me to keep my, foot in the door, keep myself close to what's happening with my patients. And I find that it's actually really enriches the work that I do.
I'm sure it's invaluable to your company, honestly, to have that end user be able to give that immediate feedback and I think when you're probably giving feedback to the team that it's heard. Well, this is great. I think these are really informative sessions, and I'm really excited to talk to you. I think I'd love for you to actually just say a little bit about your background because you told me you're from the West Indies. And I think that's an interesting place to be black from, and then come to the United States, you know, and grow up in our, and become a professional in our environment here, especially with a lot of changes going on. So I'll stay out of any political comments, but I think it'd be great if you could share a little bit about your background for folks because I think it's really interesting. And you said that it actually really informs your work.
Yeah, yes, for sure. And I'm really happy to be here and happy to share this stage with you, Dr. Tong. And so, yeah, I'm originally
Man, you're
from
gonna call me Ian. If
I
I'm
know,
calling you
Ian,
Ian, you're
it's
gonna call
so
me.
hard. So Ian, so with you, Ian. So I live and practice in DC, but I was born and raised in St. Thomas, US Virgin Islands. So drop, in the chat if you're from one of our lovely Caribbean islands. But yeah, I still go there all the time. I have most of my family is there, my siblings are there, my grandparents are there, and I stay really connected to the community through service, and I work with a foundation there. And growing up there really informed why I'm passionate about health equity. I saw, my family members have to travel. I remember traveling to Howard with my grandfather because he was having end stage kidney disease at the time and having to go back and forth and slog, when you're feeling ill to care off island and, witnessing, just trying to get some basic care at times being a struggle and the inefficiencies. And, we have great doctors there, but we continue to be challenged with resources. And though we are part of the US, we definitely have differences in the type of resources that we also receive. So it definitely informs my work and it helps to ground a lot of what I do.
Yeah. I mean, I think but that's also part of the strength of and importance of you being in this profession because so many patients go looking and they're looking for a doctor or a clinician who I think can, understand them and they don't have to explain themselves. And
Yep.
we did some work early on at Included Health. And so anyway, we made that talked to a number of individuals in professional careers at different companies that were our clients. And anyway, it was just some interesting insights about how much armoring up they have to do to like, get ready to face the healthcare industrial complex, if
Yeah,
you.
yeah, for sure. And a lot of patients, when they find me, they're super excited. That's part also of why I stay in clinical care in addition to being a leader is because I have so many patients that really value getting to see somebody that looks like them, that understands them. And I really enjoy it too. And it helps me to not get burnt out doing health equity work is seeing the actual action on the ground.
Yeah, no, that makes a lot of sense. Well, let's get into it. I mean, so we both have had some digital health experience, and I would just maybe I'll disclose early on in the formation of the app for Doctor on Demand. One thing we didn't do, we were striving for a minimal viable product and moving quickly, and so we didn't really incorporate all of the demographic data. We didn't ask for race or ethnicity at the beginning. I think ethnicity would have been a better thing to put in at that time but we ended up building a very diverse practice that so if there's time, we can certainly talk about that. But I was just going to ask you, I think we kind of missed an opportunity potentially to do something there. What do you think has to be established early in the innovation process to let or to ensure that equity becomes a core design principle or rather than an afterthought?
For sure. So one of the benefits that I have, I do both health equity work, but I also support our overall inclusion and belonging strategy. And one of the things I think is important whenever you're building an organization, building a product, and you're thinking about equity is ensuring that there's a culture of understanding that equity is a core domain of quality healthcare. It's not a nice to have. It sits along safety. Sits along timely care. And so making sure that there's this understanding that equity is something that we have to include from the very beginning, and that your leaders are championing that effort as well. But to your point of how do you build that into the innovation process, one of the things I think we should do, or it's important to do, is build in mechanisms, right? Not everybody's thinking about equity. Not everybody's going to have the experience, the expertise, the exposure to equity, and so it's important to build that into the work. Just like how you'll do a safety check, make sure that it's evidence-based. You need to say, is this equitable? Is the product that I'm creating, are the guidelines that I'm developing going to be useful for underserved populations? Is it going to be useful for the users that you are trying to engage? And we don't have to think about it in the exclusive terms, right? You want somebody to benefit. You want the majority of people using your product to benefit from it. And so when you think about equity, that really allows for you to broaden the aperture of who is able to engage with your product, your health system, et cetera. And so one example of how we do that at One Medical, I'll use a clinical guideline piece, is whenever we're developing content and clinical guidelines, we have a standard work, and we have intentionally built into that a health equity review. And so even if you aren't thinking about that as you're going down your list, you have to think about health equity because we push it, to you. And if you don't have an understanding of how that might look with your guideline or whatever you're focusing on, then we have resources to support uh, building that in. We have a health equity domain working group made up of a variety of clinicians that you can ask, pose your question to or work on a project with. And so building in the mechanism, I think, is important, and establishing, a clear mechanism for guidance so that it doesn't slow the work. You said you were kind of building fast, but you don't want the work to slow down because you're like, oh, we got to think about equity and we don't know who to ask. So that might be somebody internal, it might be a consultant, for example. And so, those are the things you want to think about. And then the last part is really education. And I know, it's not fancy in innovation because we work fast, but really taking time to educate the people on your teams who don't actually know or understand what health equity means. I'm always surprised when I'm in a conversation and people don't know what equity is. And the language and the concepts are evolving, by the minute. And so it's really important to teach folks outside of the space what it means so that they can get on board, so that they are also have accountability. And they are also bringing and generating ideas because now they understand the value that equity brings. And so those are some of the things I think about when starting a fresh or a new and innovating in the space.
That's great. Yeah, I mean, you made me think of so many different things there that we probably won't have time to go into, but just one of the things that we found was, these employee resource groups, which can be so valuable because they give, even in your title, the word is belonging there,
Mhm.
and maybe a lot of people may not know this, but belonging is added not just because it sounds good, but because it's also an evidence-based way to combat something called stereotype threat. And so it kind of came out of the literature around stereotype threat, which if you're not familiar with that concept, I definitely would. It's good reading. If anybody wants to learn about it, it's quite interesting. But it's nice to know that we have an evidence-based to way to address it. And I think those ERGs do help foster belonging. And I think it's no different than, when someone, especially someone from maybe an underserved community or under-resourced community comes into this, sort of big tower on the hill
Mhm.
of the healthcare industrial complex, and they're intimidated, and and you don't see familiar faces, and you don't see language necessarily that feels like it's speaking to you. And so there's just that's great guidance to be able to think about it early and have a systematic way that your organization can bring it in. But to tie this back to my point about the ERG is like, and the ERG actually gives language within your organization for people to have the dialogue, and so to be able to kind of make the job of equity everybody's job, not just, yeah, not just the head of health equity and belonging.
Exactly. And you could even use your ERGs to support your, business decisions and questions if you're developing a product, depending on how you structure your ERGs. You might go to those different groups, those, different patient groups that you're thinking about when you're creating and get their input as well.
Absolutely. Well, let's go. Yeah, let's go to the next question because I think this is an important thing you're touching on. So, yeah, how can healthcare organizations expand access to primary care through, either innovative delivery models and and then what impacts have you observed when they do that?
Yeah, so Ian, that we have a branding problem in primary care, and so people aren't always running to us when they're ill. But one of the ways I think we can expand access is really creating multiple access pathways to meet diverse patient needs, and also meeting patients where they are. And so I'll start with the first one. And we're seeing a lot of this popping up, but we want to think about how do we serve the patients who can't come into our brick and mortar offices? How do we serve patients who may not be able to come get care from 9 to 5 because they work, different, outside business hours? How do you serve somebody in a rural community? How do you serve the Gen Z person who may not necessarily be trying to jump into an office and they want to do it, digitally? And for a long time, a lot of primary care has been in the office with the PCP. And with time, we've seen, you've been part of that early work, seeing virtual care really expand access. And we have to continue to build on that. And right now at One Medical, in addition to our brick and mortar and our virtual care visits and our sort of 24/7 triaging, we also offer other avenues. And so we have asynchronous messaging where patients can reach out via a form, for not the sexiest way to say it, but through a form. And then they answer some questions, and asynchronously they'll get in conversation with a clinician. So it's not, AI or a chatbot. They're actually the responses are being reviewed, and then that allows people to continue on their day while having this conversation with a clinician. And we try to make sure that all of what we're doing is safe, because that's ultimately the key here. And we do that through ensuring we have clear standards around what directs us towards the patient towards an office visit, instead of that response via messaging, and when can we just send that antibiotic so that they're not ill waiting for an appointment 2 days later? So that's one.
No, but right, but I think this is important what you're making because you're giving them multiple modality, and I again, and I've referred to my age as well. You already and you hit me back. I appreciate that, so I'll just do it again. Way back in the early days, when we were doing this, I was so just to kind of go back in the way back time machine with me, talking to
I mean,
medical board.
you're not. I
No,
mean,
thank
you're.
you,
Yeah, okay.
thank you. I know what you're going to say, and thank you. I take off. But what I was going to say is, talking to these medical boards, and they didn't understand what we were doing, and so we were pretty, I think, confined to a synchronous visit. Like it all was synchronous. That's just how
Mhm.
that was sort of in the guidelines. That was what was written down in some of these requirements, and so we started there, and so that was a little bit restraining, I guess, or restrictive. So you're talking about multimodality, and I absolutely believe that multimodality improves access, opens up the opportunity for patients to engage in healthcare in different ways, and anyway, so I don't think that can be stressed enough. That is super important, and you're kind of already giving an example, I think, where, equity as a design requirement led to better healthcare delivery. But do you have is there another one that you want to use or other examples of that? I think virtual care itself and the platform itself, what is an equity platform?
Yeah.
We saw that through our workforce, to be honest, I'll speak on that but yeah, I'll let you.
Yeah, I think another way is when you're developing these programs, you have to make sure that you are thinking about the identity and the background of the patients. And so one of the ways we also get people into care is through a variety of different programs. And one that's been really successful and is actually my favorite program is our Impact by One Medical, and it's a chronic disease management program. Initially, it was just for people who had, diagnosed diabetes, hypertension, those sorts of things. But because it's been so successful, we've backed it up a little bit, and folks who are at risk can also participate. But in the design of that program, we were focused on ensuring that our clinicians, the coaches, the nurses that were involved, focus on the identity and the cultural context of the patients in the lifestyle changes and recommendations that they were delivering. And so we found that across all race and ethnicities and genders, that we saw the same improvement in outcomes. So we saw a 3 to 5 point improvement in A1C, which is huge, and
Wow.
a pretty big decrease in cholesterol as well. And so that's been one of our really successful programs because we designed equity into it from the beginning.
That's great. So that's a programmatic change and almost like an implementation, I guess, operational change. Someone asked a question in the Q&A, so I was just kind of taking a quick peek, and it said, how what was it? I think the question was like, how have it was in the guidelines, an example of adding inequity into the guidelines. Um, yeah, do you have any favorites there where sort of like, I guess, equity has built? I can think of one where, we used to use creatinine and we had a different scale of creatinine. What's an abnormal creatinine level, which is a measure of kidney function, and we had a different scale for what's abnormal for Black Americans and other and folks who were people of color, and then European Americans had a different scale, and so.
Yep, yep.
And it just turns out that the scale for African Americans and the black population was allowed them to have actually more. It sort of permitted them to have sort of less renal function or worsening renal function,
Worsening.
and they
Mhm.
were seen less, right? And they would eventually be on the transplant list later. In fact,
Yep.
right? So we were more tolerant of progressive disease in that population. So that's one that I can think of. I don't know if you have a different one, but
Yeah.
that was a guideline that changed. So.
Exactly. And that's a really powerful one. And when we in the beginning of when that was changing, we had also sent in our health equity domain working group had written out to LabCorp and the major labs, and really strongly advocated against the inclusion. And we'd actually removed it from our labs before the big announcement. And so I think that's a huge one because I think they quote thousands of lives have been saved because they're now actively on the transplant list when they weren't. And so that's a really impressive example.
Yeah, and and for people who, yeah, it's an interesting story, I would say, for people who have more time to go back and look at, because you go back to the original reason for the old guideline, and it wasn't very evidence based, right? So then you start to see where implicit bias, or
Yeah.
even structural racism, it exists probably everywhere, and certainly then it exists in the academic halls of academic medicine as well. So this is great. So yeah, so this is the I was going to ask you about sort of clinicians driving equitable innovation, despite the fact that they don't control the budgets or always control the budgets or the organizational strategy. It doesn't mean that they can't control those things, but in many cases, clinicians might be seen as, they want you for your clinical expertise. So we kind of get this might have been an example of that we just covered, but yeah, how can clinicians drive that, yeah, equitable innovation without the purse strings on the dollars and the maybe owning all the organizational strategy?
So this is my plug for getting into leadership, making sure that you are putting, your hat in the ring. When I applied for this role, I had been doing some work in equity at the organization, and I was like, you know what? I'm fairly new here, but I feel like I can do this. And I put my hat in the ring, and surprisingly, lots of people were excited and championing me. And so making sure that you put your hat in the ring, because we need clinical voices, especially as things are moving so fast, and we have a lot of not technology leaders and business leaders in medicine leading medicine. We need clinical voices. But not everybody is a leader, or not everybody wants to be in leadership, I should say. And so I think one of the biggest ways is through patient stories. It's hard to ignore a patient experience. It's easier to ignore, the numbers in a spreadsheet. And so sharing patient stories, leveraging your clinical insights, your clinical experiences, your own personal experiences, and how the system is failing your patients, particularly those who might come from underserved or under-resourced backgrounds, is a huge way we can all contribute to, awareness and change.
That's great. Yeah. Yeah. Sometimes you get in these, so I totally agree with that. Being in the leadership space for maybe for, I have a bit of an investor hat and a company building hat on now. And I think, trying to find that, trying to talk about these topics as you're identifying a leadership team, for the company. They don't all have to, be brown or black folks, but I think having them, understand that responsibility that they have in that role, and to have, to share ownership of this problem because it's everybody's problem. I actually think we're moving there more, as a society, but it's painful, right? I think we're getting there now because we see what's happening in the country and,
Mhm.
and events in different cities like Minneapolis and others. And I think, you see that and you kind of realize like, okay, we all need to be focused on this. So again, political comments aside, I will move on. Man, yeah, lots going on.
Lots going on.
Yeah, yeah. What's one system change or boundary that you think meaningfully, protected clinician time in your organization? It's kind of an interesting question, a little bit of a, turn from where we've been going here, but yeah, you have a system change that
Yeah, I'd
yeah, that
say
protected time or just made more, honestly, just
made
made
more
more
time.
time, gave more joy of the practice of medicine. Like, you know,
Yeah, yeah.
EHRs haven't exactly overjoyed clinicians, so they haven't done it. But yeah,
Yeah,
any examples?
the bane. Yeah, I mean, clinician burnout is real for any clinician on here. I'm sure at some point in time you wish there were two of you. And I've experienced burnout in my time. And so I think actually one of the things that our organization is focusing on that is a big system, it will be a big system change or is a big system change, is this focus on reducing administrative burden through tools like AI Scribes. And we released on Wednesday, I think, Health AI, which is within the app for One Medical members, and that allows our patients to ask questions, and they can actually the Health AI actually has access to their medical records. And so the
Yeah.
goal is for that to reduce the messaging burden for our staff and clinicians. It'll interpret labs for you. And if there's something abnormal or if you have a question, it will actually help you book an appointment. It'll help you get triaged to the right type of care. And so we're trying to really work on tools to reduce the burden for clinicians and think about how we're bringing back the joy in medicine by giving us more time so that for complex patients, we have more time. And we've made some progress. We've seen a 40% reduction in our administrative tasks. There's, more to go. But so I'm excited to see how the AI assistant helps me so that my patients aren't necessarily messaging me about should I do remote or should I do in person or should I, there's a lot of different questions with the
Yeah.
advent of access to information.
I think that's great. I think that yeah, that makes a lot of sense and amen to like giving clinicians back some of the joy of medicine. Actually, there was a question from someone about just sort of how are we going to get these tools into the private practices and providers. So I think they're saying like, large organizations can engage these AI tools. How do we get that into, my or, my private practice or maybe my small group? Do you have a thought on that? Not to put you on, it's a question we didn't think about before, but yeah.
I think there's a lot of companies now making these types of tools, and there's several that I can't give you all the details because I'm not looking into it for a personal practice, but there's in the doctor groups that I'm in that are affordable and that are catering to sort of the smaller practices. So there are ones out there that can support your office and your clinical setting.
Yeah, and then maybe I'll take it from the regulatory standpoint. Just in the last 10, 12 days, 15 days, let's say, the world has changed drastically. The FDA came out with the statement that if your AI does not make clinical or medical claims, then they're going to step out of the way and they want to put the tools into the hands of physicians. So I think that's a I think they're thinking that that's a goal and that'll help. There's always a slippery slope. There can be bad actors out there and they can be less rigorous evaluation of tools, but the goal there is to, I think, get more of this technology into the hands of more clinicians. Chat GPT Health was announced, and then also Doctronic is now having automated refills, right? So these are things that And again, whether I won't judge whether these are okay or not, I just think this is what's happening.
Yeah.
Our world is rapidly changing. These tools will make their way into the hands of many clinicians, and so maybe yeah, what for you? Like, what kind of tools sound promising, but most often, like, I mean, some of them are good, and then some will fail. Do you have any rubric or sort of like framework that you could to help identify the innovations that aren't going to work in the real world or going to fail in real world practice?
Yeah, I think about tools that really don't incorporate the user experience. And this is probably basic, right? But you have to co-design with the people that you're trying to produce for and iterate on that with them and get real-time feedback, especially for the busy clinician. It's going to be hard for us to go to some, other page and try to give you feedback. So building it into whatever you're doing, sitting with patients who are going to be using the product. We've done that with our senior health patients to make sure that they can use
Yeah.
the products that we're creating and are understand the workflows. And so I think tools that don't have the user experience in mind is a big one.
Yeah. Yeah. I used to, right. We've had, we never called it this, but some people would imply that there was provider-centered care. I would say more like system-centered probably at the beginning because we all work in a system. But then, there was a big push for patient-centered care. And
Hmm.
now for the last 10 years, I've sort of became aware of and have been more a fan of, calling it relationship-centered care, technologies that
Yeah.
foster or support the relationship between the two people in the room. There's usually only two people in the room when the work's being done, and so technologies that support that, and take into mind the whole patient, not just one type of patient. I think that gets us closer to it. I know they were going to warn us about time. I just want to make sure. Um, yeah, there's a great question here. As a Caribbean born and raised, how can we translate these technologies and help implement them in the Caribbean healthcare? Okay, I'm going to throw that one while I figure out how much time we have.
Yeah, that's a hard one. I think, and I think it's a challenge because we don't tend to have all of the resources in terms of like funding. I'll speak at least for the Virgin Islands. And so we have to think about how we modernize our systems in the Caribbean, and health is a big area for modernization. Telehealth is a big thing that we should be able to harness. There's obviously a lot of red tape with licensing and all of those things. But I agree with you. It's a challenging it's a challenge that we face in the Caribbean, but I think we're built for it, and we have to support, what's going on back home. I try to do that how I can, and bring these tools and communicate and educate the folks back home on these evolving and innovative tools.
Yeah, and I think there's an opportunity to get back and ask, it's like sort of get into the communities. And I mean, these tools are democratizing, like AI is democratizing access to a lot of data and information. And so it'll be interesting to see how different communities, different countries, different parts of the world, where they set their threshold for how much integration they will accept of these tools into their personal health information, into their management of their conditions. My last question really was, and I think we are probably going to run up on time, but my last question was about just what strategies have you found effective for incorporating patient and clinician voices earlier in the innovation process? And I think that's one that maybe even kind of overlaps a little bit with what we were just talking
Talk
about.
about, yeah, yeah. I mean, I'll always say the culture of feedback, people have to be interested. You have to create the environment where people are interested and willing to engage and not penalized for giving feedback. And so I think making sure that people know that you are aware that they're going to be providing feedback. I think making sure there's mechanisms for clinician and patient involvement, whether that's patient advisory councils, clinician councils, testing products, again, like I mentioned, with the patients.
Yeah.
These are all strategies that are helpful. And then the other thing is actually awareness. So when you create a product, clinicians aren't necessarily going to be running to use it, right? Because they've developed systems that help them stay on time. And so you have to increase awareness, share with them what the value proposition is, and hopefully launch it when it's a really good product so that they don't, push it to the side, and then you have to get them to come back to your product. And so making sure that I know you mentioned like when you were creating a minimal viable product, making sure that your minimum viable product is something that isn't going to deter the clinician and or the patient because it's harder to get them back.
I know with some of my colleagues, I think Carolyn Jasic was the first person I heard say this, but like minimal clinical product, minimal
Exactly.
viable clinical product, not just the minimal viable product.
Because once I looked at it and it's not working, I'm like, oh no, I don't feel like trying this again.
Yeah. Yeah. Well, I mean, there's a whole, there's a lot of bad ideas or, well-intentioned and attempts that have fallen by the wayside. But Alani, this has been great. Yeah, great discussion. I don't know if there's, I don't see it, but I know just from when we started, I think we've been talking probably for about 30 minutes, and we're a little bit over the end of the hour. I really appreciate you giving these insights, though. It's so great to have you in the role that you're in, and for an organization that's on the level of the organization that you work for is. So you all are leaders. You have lots of opportunity to continue to lead, and yeah, it's great if more of these folks can. It looks like I was just watching all the discussions, and I'm like, oh
I
yeah,
know.
a whole network is forming here
I
on the
know.
side of the chat as we're talking, which is awesome. But you all should definitely, contact us. Keep building that network, and we can keep helping each other. So thank you
Thank
so
you
much.
for the great discussion.
Yeah, you bet. How do we do, Simone? Do we finish on time? Okay.
Fantastic. What a great conversation. Drop a one in the chat if you enjoyed this conversation today. Thank you so much to you both for joining us. We are rocking and rolling through today's Health Summit. Some fantastic and interesting perspectives with some really fantastic and brilliant minds. We're so grateful. We are going to keep this thing going. I know you all have busy Fridays. And we like to stay on time. So we're going to keep going. Thank you so much to both of you. So now we are going to dive into telehealth. Telehealth has been saving me. I will tell you that. It has become a permanent part of healthcare delivery. But with that scale comes incredible amount of responsibility, right? The more people you can reach, the more potential risks there can be. How do we protect patients? How do we maintain trust? And how do we build systems that are safe by design, specifically for our communities? So, join me in a conversation today. We're going to have two clinical leaders who are thinking about this every single day. First up, I'm going to introduce Dr. Melinda Barnes. She is the Chief Medical Officer at Roe. You could have not missed Roe in this day and age, where she oversees clinical strategy, patient safety, and the development of proprietary EMR tools that support high quality care. Welcome to the conversation. And we also have Dr. Nicole Benders Hattie is the Chief Medical Officer at Talkspace. She's a board certified psychiatrist and over 15 years of experience with a deep focus on quality clinical outcomes and expanding access to mental health services. Please welcome me in joining Dr. Nicole and Dr. Melinda. Hello, hello.
Hello.
Hey there.
How you
Thanks for having
doing?
us.
All right. So, folks, first of all, as you all um, go through the conversation, please drop your questions here, either in the chat or in the Q&A section. Okay. So, as we go, I will stop and get some of your questions. I'm really personally very excited for this conversation. You all both work for incredibly impactful and dynamic organizations. Dr. Nicole, I'm going to start with a couple of questions for you.
Sure.
So, first off, from an operational standpoint, what are some of the patient safety risk in large scale telehealth? I think that a lot of people are concerned about telling their personal business in that kind of setting, right? Versus being in person. What are the things that your organizations do to kind of mitigate what potential risks there could be?
Sure, yeah. So thanks so much, Simone. It's great to be here. I'm so thrilled to be a part of this conversation. I think it's a great question to start with, right? Because, questions about patient safety lead into concerns about trust, which lead into engagement metrics, right? And so it's such an important place to start. I do think that, of course, there's, like HIPAA data security, privacy concerns that relate to patient safety as well in a digital health environment. But a primary risk in really large scale operations comes down to this challenge of fragmentation, right? Where there's small gaps, systemic gaps that really come into alignment to cause a patient safety crisis. So there's several ways that we see that that plays out, from things like missing cues, where in virtual settings, clinicians may miss physical cues of a concern, tremors that a patient may be experiencing, physical signs of self-harm that would be pretty obvious in person.
Yeah.
There's also things like geographic limitations, right? Where, I have multiple state licenses, but I'm much more familiar with crisis services in New York, where I'm located, as opposed to being able to mobilize a mobile crisis unit in a rural county in Oregon, right? So that's another example of how patient safety may come into play. But there are several ways that we have learned to mitigate these risks, right? So there's things like, crisis mapping, where we can use technology and data resourcing to surface the nearest emergency room information, the nearest police precinct, crisis stabilization units that are in place, and that can be verified with the patient's verified GPS location, right, at the start of a call. There's ways that you can use software to prevent telehealth sessions from being started without the patient confirming their physical location at the start of a call. And then another one that I think is important in terms of patient safety is around early risk detection and utilization of technology and AI tools in particular to do things like scan messages and then flag to providers when there may be indications of rising risk for a patient that enables that clinician to intervene earlier. So there's several ways, and I think that it's actually been really exciting to see the, development of patient safety tools, even in a virtual care environment.
Yeah. Telehealth for, in mental health specifically in Talkspace, I think has had an incredible last few years, particularly since the days when everyone was locked in 2020. Tell me a little bit about what that has looked like and how you all have developed over the last, few years as most people and many people are looking to engage mental health services digitally first in person.
Sure. Yeah. So, one thing that I just mentioned is the development and integration of additional like AI tools to help our providers work in a more efficient and quality focused way.
Mhm.
The other thing has just been around my focus, my primary focus within Talkspace over the last couple of years, which is around how we measure and define quality in a virtual mental health care environment. One thing that I found being really in this digital space for the last 10 plus years has been that how we define quality is highly variable depending on which stakeholder you're talking to. So to have a really robust definition of quality, what we mean by that becomes incredibly important, not only when, managing a network of providers, a large network of providers, but also when you're, proving your value and your worth to the commercial market as well. So that's led to, again, a really robust definition of quality, a strict set of quality metrics that we are tracking on a daily basis. I really map those quality metrics into a few larger buckets, right? One is things like your quality metrics, clinical quality metrics, things like evidence-based clinical assessment, your PHQ-9 for depression tracking, your GAD-7 for anxiety tracking, to see how quickly patient scores are actually reducing with the implementation of virtual care. There's also things like quality of service metrics that we really closely track, and you can think of that as things like your provider professionalism metrics, what availability is, which impacts time to care, late cancellations, no-show rates, timely responses to messages, documentation completion and quality. And then finally, your patient experience metrics, which are really important, again, especially in mental health care, looking at things like patient satisfaction. You can look at NPS scores. And then, of course, you can look at engagement, which you can measure through things like the working alliance inventory, which really measures the quote unquote bond between a patient and their provider, which is really a primary indicator of success.
Thank you for that. I think there's been a lot of conversation today about how people define quality. So we'll probably circle back around to that. Dr. Melinda, great to have you. Thank you for joining us again today. For clinicians who are established in the traditional practice, meaning they are very used to their traditional way of practicing whatever their space is, and considering adding telehealth, what would you say to them? What kind of mindset shift do they need in order to kind of think about expanding into virtual care? We have a lot of clinicians here on today's call, and so these are kind of some of the conversations or questions that surfaced.
That's a wonderful question. Yeah, thank you so much for having me here. I'm super happy to see you again, Simone, and Nicole as well. I would say the number one thing in terms of like getting your mindset right is be prepared. Virtual care and in-person care are not the same, and virtual care is not just digital in-person care. You shouldn't, you don't, and we're not necessarily trying to replicate in-person care through Zoom. And what I mean by that is there are limitations to your scale, your ability to take care of patients in person. They have to
Mhm.
physically come to you. They are in your space for maybe 20 minutes, 30 minutes, depending on what your specialty is. You have a waiting room. The building is only open from 9 to 5. So if you try to replicate that virtually, you are going to lose out on a lot of the benefits of virtual care, right? Dr. Nicole just said she's licensed in a lot of states. I'm licensed in all 50 states plus DC. So I can see just from that, my span, my reach of patients is completely greater than when I was seeing patients only in person in New York City or in Connecticut, right? People could drive in from Boston if they wanted to,
Mhm.
but no one's flying in necessarily from Oregon or California on a short notice to see me. And so thinking through how do you leverage tools that are better suited for virtual care than they might be in persons, right? So we talked about AI and technology. Right there, how does you can we use those tools in person as well. But if I'm seeing someone virtually, that means I have the ability to see them either real time through a synchronous encounter, right? Which could be synchronous video like we're doing right now. We could do a synchronous phone call, or the beauty is you can do asynchronous. And everyone who's a clinician, you have engaged in asynchronous care. Anytime a patient sends you a message with some symptoms, some clinical information, and from that information, you come up with a treatment plan, which could result in a prescription or giving reassurance. That is asynchronous. You took information, you and the patient are not in the same space or time. You took that information and made a clinical decision for that patient. So asynchronous care is now becoming a cornerstone of virtual care. 20 years ago, if you said virtual care, it meant synchronous video. It was logging in, doctors in their chair, you're in your chair, and you're having a conversation. It was meant to mimic in-person care. Now, asynchronous is becoming the cornerstone where you can do these store and forward messages, and that means attaching video or photos or nothing. And what
Mhm.
that has allowed us to do is to really structure the information, right? So there's all these things that a computer can do that they're better at than we are. One of them is managing huge amounts of data. It's also identifying patterns. And so you can write a structured visit, everything that you wanted to ask a patient about mental health or obesity or sinus infections. You can put that. And what we do on the clinical team is we write those questions, we write the answer choices, but we also write the logic. So if they answer A, it's not multiple choice like that, but if they answer sort of like, I've had a sinus infection for more than 2 weeks, versus I've had slight drainage for an hour, the follow-up question will be very different, right? And that follow-up
Mhm.
question and what the next set of questions looks like is written by the clinical team. So you have a dynamic, very smart intake that can then route patients to different practitioners. It can sort urgency. It can even respond to patients and say something like, oh, based on what you're saying, you should actually go see someone in person, right? So that's not something that you can do in person. And so having that mindset of, I'm not trying to replicate in person. I want to understand what are the benefits of virtual care and how can I adopt my practice to understand that. And I think one of the big things is that asynchronous. And then the second thing that I think is kind of a mindset shift is sort of bringing the hospitality, right? In
Mhm.
person, We have about 3 to 5 seconds to convey trust, empathy, competency, like with the patient. They walk into your office, just the waiting room, the parking lot, the way the building looks. They may be like, oh no, this looks a little shady, or wow, this is going to be a great doctor, right? And then
Yeah.
you walk in and you have confidence, you have presence, you sit down, you greet the person, they're feeling good. How do you do that virtually? How do you
Yeah.
make someone feel warm? How do you instill trust and competency in that? I like to say when we build our visits, we have to show them that we know them, right? So the questions that we ask, the follow-up questions, that is instilling trust and competency because if you tell me that you're having sinus pain and I say, "Well, how's your foot?" You're not probably feeling very confident in my ability to understand sinusitis. And so that's like part of it. Again, that's something that you can do like right now in person, you may be feeling rushed. I got to get through these visits. I have 10 minutes to see 5 people. Believe it or not, virtual care, especially asynchronous, you don't have to be rushed. The patient comes in, they do their part, you get their chart, you take a look. Also, you layer technology on top of that. So that's additional clinical decision support. We use all of our structured information for patient safety. I could go into that a ton, but like Dr. Nicole said, you can use that to identify people who are at risk. With scale comes compression of experience. I say, what's the difference between a doctor who's been in practice 40 years and one who's been in practice for 4 years? It is that lifetime experience, is recognizing those patterns and saying, you know what, I'm not worried this patient's going to get better. When you have scale, you can compress time, right? So if we
Mm.
see 40,000 patients with this same thing, we now have the same experience or more than someone who's been in practice for 40 years. We feed that back into our product. So now we know how to recognize when patients might experience side effects faster and get medication to them proactively. We can reach out to them on day 2 and say, hey, how are you doing? Because we know that 90% of patients who have this profile might experience side effects on day 2. So there's a lot of amazing things about virtual care. In person, we need it, we love it. It's not about which one's better. It's about what is the right care delivery model at the right time for the right patient. And so if you think about it that way, when you're building out your practice or if you're evaluating platforms that you want to join, think about it that way. Are they filtering out patients so that I'm seeing the right patient on this platform versus someone who should be seen in person? And that can help you have trust that the patients that you're seeing are actually great candidates.
If I may, Dr. Melinda,
Absolutely.
I love everything that you just said. I love that we're talking about trust. I've like t coined this term webside manner as opposed to bedside manner in digital health in general. And it's something that absolutely requires, training on, right? It's not how you and I trained, I think, in medical school and residency years ago, but it really becomes so important to getting the kinds of clinical outcomes that we want to see. And then the asynchronous piece too, right? I think that that is such a unique advantage of digital health companies is that we have access to all of this data to be able to track all of the types of quality metrics that I was talking about before, to analyze that data not only in unique ways, but in more efficient ways that allows us to glean learnings from that data to adapt treatment approach, treatment plans, approach to different patient populations in really unique ways just by taking advantage of the technology.
Yeah, 100%.
Great. Thank you for sharing that. We've got a couple questions coming through the chat, so I'm actually going to pivot there and ask some of the audience questions. So I'm going to start with you, Dr. Nicole. As you scale care through a digital platform, how do you ensure that community trust, cultural responsiveness, and equity remain central, especially for populations that have historically been underserved by traditional mental health systems? I think this is incredibly important for our group to have discussion about. This question came from Tamika McCullough.
Thank you, Tamika. I really appreciate the question. And again, like this notion of trust in a digital first virtual care environment becomes incredibly important. Trust in digital health, first of all, can be fragile at best, but I think really hinges on these notions of transparency and accountability. And what that looks like for different patient populations is really important to pay attention to, right? So there are several things I think that are, sort of table stakes for patient safety and privacy. One of those things being, things like data integrity, right? Making sure your data is accurate, it's consistent, that there's data protection and encryption safeguards that are in place to protect protected health information from unauthorized access. There's also things around provider continuity that I think is really important in trust, and especially again in mental health care, where the therapeutic relationship, the longitudinal therapeutic relationship becomes super important for developing that relationship and to get people to come back again and again in order to complete their treatment plan. But there's also something I think where, there's a focus on clinical quality, what those quality outcomes look like across different patient populations that becomes really important to pay attention to as well in order to, ensure that traditionally, marginalized communities have that same level of trust, right? A lot of that comes down to modeling, right? And there's cultural competence training that we can provide across our networks of providers, but also culturally concordant care, right? Being able to see a therapist or a psychiatrist that actually looks like you and can understand your lived experience is something that we're really focused on as well. And I think it's really just, not just a voiceover to it, but a commitment to those types of things and developing your workforce and training baselines, but also ongoing assessment of the quality of care that's being delivered within your network that you just have to stay on top of in order to make sure that this remains a focus.
Yeah, yeah, absolutely. For this question, I'm gonna kind of merge page one of the questions from the chat with our initial question. So, Dr. Melinda, Row is growing and scaling pretty quickly, at least from the outset in. How do you continue to manage that kind of speed and innovation with clinical rigor?
It's a great question. So we have company principles and we have principles within the affiliated medical practice. And one is safety is paramount. So, you know, early in the beginning of the company, I said, Facebook, and I think whenever Mark Zuckerberg said, you're going to go fast and break things and, kind of figure it out, I'm like, we are not going to do that. We can go fast, but not so fast where we have to break something, right?
Hmm.
We are dealing
Yeah.
with people, with their health, with their lives, their well-being. That's not something that we can do, right? We've taken the Hippocratic Oath. We have a responsibility to be very much responsible and to remember, even if you are writing code in service of someone's health, right? You're on the FP&A team in service of someone's health. And I think reminding them of that. And so we don't our speed and our innovation cannot outpace safety. I think that's, the like simple answer is that you have to have those guardrails. You have to have the right people in the room to say, wait a minute, on the last call they said the minimal, clinical product, not just minimal viable product. That's exactly
Hmm.
right, right? And that is the role of people on my team and myself. Do we have the minimum amount of aspects and features to this new initiative to make sure that patients are not harmed? And that means that we have to have an audit, an auditing program. We have quality and safety monitoring this. We have access to data. We understand what trade-offs we might be making, and then we can put operational buffers around that. I always talk about the Swiss cheese model of how like never events or near misses happen, and it's just when all the holes in that Swiss cheese ladder up or line up, and then the error happens. But the more layers of protection you have, the more or I say the less likely it is that all those holes line up for an error to happen. So we have the digital product. We also wrap that around with physical people, right? Nurses that are reading charts, nurses that are pulling different charts that may have different aspects in them that's flagging to us for an audit review. Also having engineers look at things, right? you talk to the engineers and say, look, these are the kind of things that I'm worried about. If you see a patient who has multiple medications or you see a patient who has this, can you flag that to us? And I'm sure people are thinking, really, the engineers? Yes, they love that, right? They are working at a healthcare company and they love that they're invested in that. So ultimately, you have to have the right people in the room. You have to make sure that you can go fast. But in order to go fast, everyone has to be on the same page. We have to know what are acceptable trade-offs and what are, never events, things that can't happen. And so again, anything that can harm patients is a no-go. And then we have to be able to have that like accusation audit, sit down and say, this is what I'm planning on doing. What do people think? Like, what can go wrong here? What am I missing? And I'm never, people say, we have another principle that's like care more about getting it right than being right. And we'll just put that, hashtag care more about getting it right than being right. So like give me that feedback. What am I missing? And that's like how you go. And I think the other thing obviously is like embracing technology. Like we have to, you cannot boil the ocean. You can't build everything. You'll notice, Ro, we do not treat every condition out there, right? We
Mhm.
are 8 years old and we treat a select number of conditions. Why? Because I can go deep in the clinical aspect of that. I can go deep in the intersection of clinical and tech. I can understand how to make the product better. The engineers are understanding, the product managers, data, growth. We're all working together, rallied around a couple of things to make that better, to build the infrastructure to add more. But if we started with just come to us, if we're a restaurant, come to us, we have food.
Yeah.
Like, how do you make everything on your menu amazing if you offer everything, as opposed to like six bespoke dishes? And so that was our approach to how we could have speed, innovation, and quality and safety. It's just we say also drive quality through focus. You guys are getting all the roisms. But these are the principles that we live by that I think have made us really successful.
Great. Thank you for sharing that. I'm going to go back to one of the questions here in the chat. So, health equity often breaks down after the clinical visit. How do you see AI supporting continuity of care in communities where people may not have ongoing access to providers, but do engage with movement, fitness, and community-based healthcare services? This probably goes towards Dr. Nicole, but either of you are welcome to answer.
Sure, no, I'm happy to jump in. I mean, and really I appreciate the question. I think it comes down again to us really seeing this level of access to data is an incredibly positive and positively reinforcing thing, right? So, not everyone's going to have ongoing access to providers. There's so many barriers to care out there, especially mental health care, whether that's transportation, cost, shortage of providers. There's always these barriers to care that are out there. And so to be able to provide access to services outside of face-to-face, even virtual face-to-face providers is incredibly important. So whether that is leaning into, self-guided, education and content that we can provide for individuals, peer services that we can provide to individuals, but also other asynchronous data, right? It's fitness tracking, it's sleep tracking, being able to pull all of that information in and to do analysis of it over time becomes incredibly important, right? I mean, we certainly know that there are, challenges associated with the cost of our healthcare system in this country overall. And that often leads to me having conversations about, clinicians working at the top of their license, right? And so being able to and analyze all of this additional information, do research on it in a culturally competent way to understand how someone moving around in their community may be a predictive of symptoms of depression, how often they are staying at their home or engaging in exercise or engaging in other community-based support systems has a direct implication on their mental health and how well they will be functioning at work, in social settings, with the rest of the supports in their lives. So again, I think it comes down to, really embracing this plethora of data that we have at our disposal in order to not further exacerbate inequities in care and be able to take care of all the patients who are coming to us.
I think
Fantastic.
Go
Oh, if I
ahead,
could just
Dr.
add one
Melinda.
point, I know we're at time, but I do think that we cannot like overestimate the value of like compressing the gap in health literacy for
Mm,
patients, right? So the education part is huge, but also their patients' access to their own data in a way that they can understand is going to be huge because we've been talking about like EMR integration for decades. And where it's really going to come down to is data portability. If I can carry my data on my smartphone and just show it to somebody, that's probably going to happen faster than having Epic talk to Cerner or talk to all these other hospital systems, right? And so I think
hmm
when you talk about the community, it's how are you getting education to people who care about health, your yoga instructor, the rumble boxing, whatever that is. But then how do you also get information to patients on their smartphone or whatever their device is in a way that they feel comfortable sharing it with their movement instructor? How do you get
hmm
education to them as well? So the getting the ecosystem integrated, I think that is the ideal. I think that that takes a long time to accomplish that. But we have to find ways to leverage. Obviously, everyone, you can download the Chat GPT app on your phone, and that is probably the first step, right? Of people putting it in there, asking friends. And so I think getting people to feel comfortable talking about health topics, close that gap, and then make it easier for people to carry their data in easy to understand ways will help them get that continuity of care outside of just the doctor's office.
Thank you. Man, we've got questions flying in. I feel like we could keep this conversation going for another half hour. But that's a good sign. It is a fantastic sign. So we are going to, as a team, try to answer some of your questions. But I just want to say thank you so much, Dr. Nicole and Dr. Melinda, for this brief but impactful conversation. It has been fantastic to have you all here and appreciate your time. Thank you so much. If you've enjoyed this conversation, please drop a quick one in the chat. All right, before you all go, I want to share a couple of things with the general audience, and lots of ones for you all. So thank you so much for joining today. I'm going to close out our conversation just by sharing a few things that our team has in store for the next couple of sessions and things that we have going on. So give me one second. I'm going to share my screen here, folks. I think I'm going to share my screen. Let's see. All righty. So, one, we've had a really great conversation today. We've had conversations that have spanned from health equity to operators who are operating huge health systems, and some fantastic conversations about how people are integrating AI and using agentic AI in their day-to-day practice. Afrotech and HealthStack is bringing something new to our community in the next year. At Afrotech Conference this year, we will be hosting the HealthStack Conference, which is dedicated to these types of conversation. It is expanded on everything we've talked about today, plus more. It'll be multiple days of programming focused on healthcare innovation, on health equity, on clinical leadership, and real world implementation. So, our goal is that you all walk away with tangible, tactical insights that help you to do your jobs better, including CME credits. So, we will be sharing more, but today, for folks who have joined us, we'd like to give you a 20% off through Monday, only through Monday, guys, specifically for the Health Stack conference ticket. That also includes access to Afrotech conference as well. So if you have your phone, go ahead and grab the screenshot or grab the QR code to get your 20% off code. The code is HealthStack20. HealthStack 20 at checkout if you use that, and it is valid through Monday. We will drop the link in the chat as well. We are so excited for today's conversation. Thank you so much for joining us, and we will see you in Houston in November. Thanks, everybody. Bye. Happy Friday.